As noted, I'm here with AMA President Dr. Rinaldi to discuss how implementation of the new agreement with the AMA is coming along. As the Premier outlined in my mandate letter, we are committed to fully implementing the AMA agreement. We're working closely with the AMA to implement all the components of the deal as soon as possible. Now, the first thing that we're doing is rescinding the cap on daily visits. It applies to all services that are billed as visits, such as office visits, consultation, and counseling services. Procedures and tests that physicians provide in a day are not billed as visits. Now, right now, services that are billed as visits are discounted if physicians provide over 50 in one day. So with this change, physicians will be fully compensated no matter how many visit services they bill in a given day. Now, we're making the change because we've heard from physicians, particularly ophthalmologists, family physicians, and pediatricians who say this cap limits patient access. Now, changing the policy will address immediate pressures and increase patient access to services provided by general practitioners and specialists. Now, the intent was to promote quality care and safety for patients and physicians, and those are valid goals. But the impact of the cap was limited, and we think it's outweighed by the need to support access for patients and let physicians use their judgment to ensure they're seeing the appropriate number of patients in a day. And the fact is, the cap was a source of frustration for physicians. As I've said from the start, this agreement is about more than money. It's about listening to doctors and acting on their concerns. And I mean that, and it's important to follow through on it. This is a relatively small item in terms of the agreement overall, likely about $22 million a year, but it shows where we're going. I said we were committed to rebuilding our relationship with doctors based on trust and collaboration, and that's what we're doing. And we'll keep working with the AMA to review the change and assess its impact to determine future policy beyond the current fiscal year. We're also moving forward to implement the 1% rate increase for 22-23 and the 1% recognition lump sum payment. Now, the recognition payment totals approximately $45 million and will go to the AMA for distribution to their members by the end of this year. It recognizes the exceptional contributions made by physicians during the pandemic in 2021-2022. We're also working with the AMA to implement the 1% rate increase for 2022-23. Now, the increase applies to fee-for-service and alternative relationship plan rates, and will provide an additional $46 million to physicians. Now, as outlined in the agreement, the rate increase is heavily weighted to specialties facing the greatest pressures, such as family medicine. We're working with the AMA to distribute these increases across and within specialties. Increases will be effective April 1st, 2022, and are expected to be finalized by March 31st of 2023. I'm very happy to be moving forward based on the agreement and to be working with the AMA and Dr. Rinaldi. The agreement will help to stabilize the health system, target areas of concern, and to support Albertans' healthcare needs. It recognizes the service our physicians have provided to Albertans through the pandemic and the services they provide each and every day. We still have a lot of work to do, and we're going to stick at it. We need to rebuild our healthcare workforce overall to support the changes we're making within AHS and in the larger system, including primary care and continuing care. And we're moving forward with all that work as well. We're sending a message that healthcare is a great career in spite of the strains of the past 3 years, and Alberta is the best place in Canada to build it. We promised Albertans a stronger publicly funded health system with better access to care, and this is another step towards delivering on that promise. So again, thank you so much for coming, and I'd now like to pass it over to Dr. Rinaldi, who will say a few words.
Thank you, Minister Copping. I really look forward to this, and I hope that we do provide you with some interesting information moving forward. So the past 6 weeks have been a test of the potential of this agreement between the Alberta government and the Alberta Medical Association. Now, there's still a great deal of work to be done ahead, but I can say that with hard work and shared intent, we have accomplished some of the first things that needed to be achieved. You are hearing about some of that work today. In our healthcare system today, the number one issue to address is the shortage of health human resources, including doctors and everyone on the healthcare team. We are competing nationally and internationally for every individual, and I think this will continue to be our primary challenge for some time. In our competitive market, keeping Alberta physicians here and attracting them from other places has a lot to do with how stable their practices will be. Like all Alberta businesses, physicians have been struggling with rising costs to run their businesses, pay their staff, and to serve their patients. That's why it was important to get moving on the things that we are announcing today. Provisional removal of the daily service caps will allow physicians to care for more patients where the cap had prevented them from doing so. This will improve access to care for patients and appropriate access to the appropriate place. So that's the first good news. It would also help stabilize the financial state of physician practices and businesses. The one-time payment is also appreciated for the same reason. There will be more support for physicians ahead in the provisions of other provisions of the agreement. So thank you to the Minister and his team for working with us to reach this first milestone. It is really, truly enjoyable to be in a positive relationship. We look forward to more collaboration to deliver the full potential of this agreement.
Thanks very much, Dr. Rinaldi and Minister Copping. So with that, we'll open it for questions. We have a lot of outlets on the line and not all day to do the Q&A. So we'll ask you to limit to one reporter per outlet. We'll start with Dean Bennett, and then we'll go to Global Edmonton and CTV Calgary. So thanks. Dean?
Thanks. Thanks, Minister. So is this, who asked for this change to the 50 cap then? 50 visit, was that sort of a mutual thing, or who asked for the change?
So I can start, and maybe Dr. Rinaldi, if you want to. So this was a joint conversation that was had between the AMA and Alberta Health. This was an issue raised by the AMA, and quite frankly, when we, one of the key processes that we engaged in as part of our renegotiation was an interest-based process, and identifying the interest of the AMA, the interests of Alberta Health, and we found that we have a lot of common interests, like not only for, retention and attraction of doctors, but also in regards to access to services. So, this was an issue raised by the AMA, but it actually aligned with both of our interests, and that's why it was, put in as part of the agreement. But Dr. Rinaldi, if you want to comment further on that.
I think you pretty well answered it. Yeah, this was part of interest-based negotiations. The cap was imposed when the prior AMA agreement was revoked. So as we move forward on issues that would help us system-wise going forward, not just physicians, but the system, the cap was one of the issues that came up because it significantly interfered with access and also with physician stability in office.
Okay.
Thanks for that. Oh, sorry, Dean, follow-up?
No follow-up. I'm fine, thanks.
Okay. Thanks, Dean. So I'm sorry, I'm just looking at the queue. It's different than I'm used to, so I think my order might not have been right. We'll go to Tyson Fedor with CTV next, please.
Hey guys, can you hear me now? Perfect. I didn't expect to be second in the queue here as also. Minister Copping, I just kind of want to address some comments made by the Premier in regards to health spending accounts. Is that something you've spoken to the Premier about potentially, and what that could look like in the future? I know it's not in your mandate letter, but is that something you have addressed with the Premier?
Yeah, so as the Premier stated, health savings accounts, the purpose are to help Albertans pay for costs that are not covered by our publicly funded healthcare system. And I think the Premier spoke to this very briefly last week as well, indicating, what her vision was for that. But that's something we'll be working with over the next number of weeks.
And just a quick follow-up for Dr. Rinaldi. Is that something the AMA has looked at? Is that something that you guys would support if it was brought in by the province?
I won't comment on whether we support because it's very preliminary at this point in time. I mean, we're here to talk about this announcement and progress on the agreement to date. there's a lot of work to do and still a lot of things to move forward on. But I would prefer to focus on the topics that were assigned press conference.
Okay. Thanks for that, Dr. Rinaldi. So next in the queue is Janet from CBC.
Hi there. Thanks for taking my question. First, I'm just looking for a bit more information from Minister Copping on the hard cap. So if I recall correctly, there was also a hard cap of 65 total patients during the day that a doctor could see. And I'm wondering if that cap of a maximum number of 65 that they can bill for at all does remain in place or will remain in place. And also, what is the effectiveness date of this new policy?
Yeah, so you're quite right. It was really a cap and related to in regards to payment. So the 0 to 50 was at 100%. 51 to 65 was at 50%, and then those above 65 were paid at 0%. So what this is doing is actually leaving it up to physicians to decide what is the appropriate number to see in a given day, and then all will be paid at 100%. And the long story short is what we heard from physicians and also from the AMA is that for some this impacted their ability to run, for example, evening clinics. So we will be working with the AMA in terms of measuring the impact this has in terms of access to care, but also we want to ensure that the doctors don't burn themselves out. So we're letting them make the call, but we'll be watching that very closely, and that's why we're putting it in on an interim basis. I don't know if Dr. Rinaldi, you want to speak further on that?
Yeah, the cap essentially reduced access for patients because once the cap was reached, physicians would be paid less or not at all for seeing patients. So this meant that some clinics had to close or close early. Patients ended up in the emergency department, and that often is not the appropriate place for them to be. But to clarify, the cap doesn't apply. I know we use the word visits, but it applies to a number of services, not the number of patients. So a patient could have several services attached to that visit that would add up to the cap of 50 or 65. So it's not number of patients, it is actually a number of services. So that makes it add up quickly. And if you look at divisions like ophthalmology, where they may have 8 or 10 stations before the physician actually sees them, all of those are services that are included for that patient, but the physician time is maybe 10% of that entire visit because the rest is technical assessment and stuff. So let's just not confuse it with it's the number of patients, because I think that sort of leads people to believe that there's some kind of a volume rush quality deprecation that's not true.
Thanks, Dr. Rinaldi. And sorry, the other questions that you had was in regards to timing. We do have to make some IT changes to our system, so that's going to take a little bit of time. So as soon as those changes are in place, then we are going to put out a bulletin, and then this change will take effect as soon as we can make those IT changes.
And if I can just add, I know I used the word provisional, but this at this point currently extends to the end of this fiscal year, and then will be reassessed based on impact and stuff. So it's provisional in that sense. So that's till the end of March 23.
Okay, thanks, Dr. Rinaldi. So we'll go next to Sarah Comadina from Global.
Hello, thank you for taking my question. With no longer having this cap on services, is there a risk that this could impact the quality of care that is provided by the physician?
So I'll answer that first. I think I just addressed that, right? That's not the intent. Physicians are professionals. I mean, we can always run on the one bad apple in a group, but physicians are here to provide quality care. That's the integrity we have as professionals. So I don't believe that there's never anything that's risk-free, but that's the way the world was before 2020 when the cap was set in. And I don't believe that that's an accurate reflection of the majority of how business will be conducted or how patients will be cared for.
Minister, did you want to add to that, or we'll go to your follow-up, Sarah?
Yeah, the only other additional comment is, and I agree entirely with Dr. Rinaldi, we spoke about this particular issue when we were, discussing the change, and as well, the college continues to provide oversight in terms of quality of care.
Thanks for that, Minister. So, Sarah, follow-up?
When this cap was first, so
We lost you, Sarah.
sorry, this cap wasn't there for that long. So, right now, like, are we seeing direct impacts from having this service cap, like right now? Is that part of the issue that we're seeing with emergency rooms, or is it too hard to say?
I think it's certainly part of it. We can contribute parts of it to COVID, but when you ask physicians to open extra hours and they've already hit their cap during their daytime hours, we're not Florence Nightingale, right? So yeah, it absolutely does have an impact. Whether we can quantify that versus COVID versus other things versus the loss of physicians during that period where we had no agreement and COVID coexisted, I don't think we can come up with the exact numbers, but I think you can definitely attribute some of that line up and increases in other wait times in inappropriate places to the cap.
And one thing we will be measuring is the number of people who go over the cap, and also we'll be looking at the hours that services are being provided to assess when we remove it, what the impact is. But what we have heard from doctors and the conversations we had with the AMA is that for some, this impacted their ability to, for example, for like family physicians to run an evening clinic. And what you see, if they're not running an evening clinic, that puts more pressures on our acute care system if people can't get in to see their family doctor. So this will help relieve that pressure.
Thanks for that, Minister. We'll go next to Catherine Grukowski.
Hi, thanks for taking my question. So I know you said you're going to be monitoring this, but I'm wondering if there's any quantity or how much do you think this will add in terms of capacity to the system, whether that be measured in the number of patients or the number of services or the physician equivalents that it would be adding, or can you give any estimate to how much this will expand capacity?
Yeah, we don't have an exact number because we're going to have to wait and see. We do know that before the daily cap, there were a number of days that physicians exceeded the 66 visit services or over the 50 visit services. That dropped significantly after the daily cap, which they still could, but it just wasn't compensated at the same rate. So we expect an increase. But we don't have, time will tell in terms of what the exact amount is. But we do know that it will, based on anecdotally, and we believe that it will actually make a difference. Dr. Rinaldi, I don't know if you want to speak further to this.
Yeah, no, I mean, we don't know, right? We're going to try to follow it and see.
Okay, and in the mandate letter, there was mention specifically of the alternative compensation model. And I know that was initially slated to be done over the course of the agreement, but I'm wondering, is that work being expedited at all? Or is this timeline for the alternate compensation model still the course of the agreement?
I'll start and then Dr. Rinaldi step in. So, this is one of the elements of the agreement that I'm personally very excited about in terms of, working together to improve the different alternate methods of pay and to actually expand that. So, that work is going to be moving forward. Now, obviously, we're going to expand it over the course of the entire agreement, but we already have a number of different methods of pay that are in place. Like, for example, a blended capitation model. We can still do some tweaking. So, from my perspective, that's something that I'd like to actually drive faster sooner. To look at different methods and how we can use that to support particularly family physicians and ensure that they have a method of pay that wants to keep them here and then also promotes them working with allied health professionals. We have some models already in place, and now it's looking at how do we tweak those models and then drive them forward. And that is one of the key issues on my list, particularly given the challenges that we have in primary care. And I'm not jumping the gun on this, but it'll be interesting to see what I'm very much looking forward to the task force, the Modernizing Alberta's Primary Care System task force comes out with. They'll be coming out with some quick hit recommendations. Some of them may touch on this aspect, but it's something that I think is critically important that we work on. And Dr. Rinaldi, I don't know if you want to care to comment on that.
I mean, some of the time frame is related to just the technicalities of setting it up, and so we would absolutely work to improving the efficiencies in that. The other thing is whether it's blended CAP or an ARP. These are a group of physicians who get together to provide a set of services. So first of all, they all have to get along. Second of all, they have to decide how they're going to divide the income they get within that ARP. So, you just can't throw 6 people in a room and say, sign this piece of paper and move on. So there's some human resource and human nature issues related to the same. And then beyond that, of course, is the resources that are available for allied health professionals to support those agreements. So some of it's technical, but some of it just is labor relations in that more looser sense. So yeah, it won't be immediate, I guess is what I'm saying.
Thanks, Dr. Rinaldi. We've got time for a couple more, so we'll go to Alana Smith with the Globe.
Can you guys hear me okay? Oh, awesome. Okay, great. Thanks for taking my question. Sorry, it's a bit off topic. I just had a few follow-ups for you, Mr. Copping, on the announcement from last week on EMS reform. So I know that included empowering paramedics to, triage whether a patient needs to be transferred to an ER via ambulance. I'm wondering if there are any liability concerns with a move like that. Like, what if they get the diagnosis wrong?
So we'll be looking to support paramedics in terms of making that call with whether it be telephone or online support. Online support from a doctor in terms of assisting them and making that call. And then on the liability question, we will assess that. But at the end of the day, it's the paramedic. They're highly trained professionals. They'll be able to do the assessment if they want some assistance. They'll be able to call in and then be able to get further assistance to be able to make that call. But we fully appreciate that there's some people that are transporting don't actually need to be transferred to hospital, can be treated on site, and this is a process that we see actually happening in other jurisdictions in this country and in other jurisdictions around the world. So we know it can be done, and we're looking forward to supporting our paramedics and making that call. And not only from a training standpoint that what they already have, but be able to call back and get advice from a doctor should they feel they need to do so.
Thank you for that. And then a second question for you. I'm just wondering and I don't know if you spoke about this last week, so apologies if you did, but what about giving control back to municipalities for 911 dispatch? Is that a possibility or something that you're having conversations with cities for right now? So
we do have we just have received an independent review in terms of dispatch. So we're reviewing that. My colleague MLA Sigurdsson, as a parliamentary secretary for EMS, is taking a look at it, and then we'll be working through that to see, okay, where do we go from here? But we were very clear with Dr. Cowell in terms of reducing EMS wait times is a critical delivery. When we take a look at the dispatch piece, that doesn't actually add lots of time to the call. But in terms of dispatch rules, we've already made some significant changes, keeping EMS units in rural areas more often than not. And we've seen a significant improvement, particularly outside of Calgary and also outside of Edmonton, in regards to local ambulances staying local longer. But we'll be reviewing that report and then respond to that over the coming weeks.
Thank you.
Thanks for that. We'll go to Madeline Smith with the Journal, and then we'll have time for one more after that.
Hi there, can you hear me okay? Great. So I apologize for this. I just want to ensure that I understand this correctly. Is what you're talking about today something that was in the agreement that you're now moving forward on, or is it a change from the agreement that you had a few weeks ago?
No, it's formed part of the agreement that one of the first things we would do would be looking at easing these restrictions and come to an agreement to be able to make that happen. And that's what we're announcing today reflects that. Dr. Rinaldi, anything to add?
Nope, you're 100% right.
Okay, thank you for that. And as well, Minister, as you know, part of the agreement was a promise to repeal a change that had allowed the government to unilaterally end a master agreement with doctors. When will the government be bringing legislation to that effect?
Yeah, my intent is to bring it forward this fall session, and it's going through the process right now.
Thank you.
Thanks for that. And for our final question, we'll go to Audrey Neveu from CBC French.
Hi, thanks for taking my question. My first one is for Dr. Rinaldi. Doctor, many people say that one of the issues leading to the long emergency wait times is a lack of access to family doctors. In your mind, what's the most important action the government could take right now beyond the existing agreement to recruit and retain family physicians in the province?
Well, I think the removal of the daily cap is a good first step forward. Beyond that, I think we're working towards and the one-time payment. Those are the issues are financial stability. You know, doctors have left the province. Doctors have changed their practices to go into more niche practices, like maybe OR assist, rather than trying to run an office that's financially non-sustainable. So those are definitely options that are on the table. Obviously, there are other providers who feel they can provide the same service as family physicians, and they have every opportunity to present their case and be included as providers. But I think the biggest issue is financial stability, that physicians can look ahead and see over the next couple of years that they can actually keep their business afloat, because most of them are in family medicine because they like to practice it, right? And for some of the specialties, again, they're there because they enjoy what they do, right? That's why we maybe have lived as long as we have under circumstances that are less than positive. We didn't all just say, well, I think I'll just take off and, manage a sports team or something like that. So it's the stability that's huge, right? And with that comes kind of a positive sense, because I know, at least in family medicine, I've had several people write to the president to say, I teach students all the time and I can't do it anymore because I know none of them want to do what I do, right? So we have to make it a positive, attractive environment.
And if I could just add to that, I agree wholeheartedly with Dr. Rinaldi. Like, this agreement provides stability. That was one of the big things that we talked about, because, as you know, for family physicians, well, most physicians, there are private businesses. So having a certainty in regards to their revenue stream, like over the course of the agreement, this does that. Plus, we spent a lot of time focusing on where were the biggest challenges. So we agreed on the approach that we're gonna over the course of the agreement, we're gonna funnel more dollars to family physicians and other those community-based physicians where there's a higher need, recognizing internal equity issues, but also recognizing our need to have more family physicians, retention and then attraction. And that's why, again, I'm excited about the innovation pieces in this agreement, looking at different methods of pay. How do we improve what we have already to continue to attract, not only keep the physicians we have, but attract other physicians, because it's not necessarily a one size fits all. Fee-for-service model works very good for some, but for others, they want a different approach. So to be able to provide those options and ensure that for family physicians that are entering into, or physicians who are entering into the workforce, they want to be family physicians, and B, they want to practice here in Alberta.
Thanks, Minister.
Thank
So
you.
final
And,
question of the day, follow-up, Audrey?
So, yes, thank you. Well, my question could be for both of you, actually. A lot of the contentious aspect in the agreement involves striking those negotiating committees to deal with those afterwards. So what are these leftover outstanding issues, and which are you most hopeful of resolving, and why?
Do you want me to start, Dr. Rinaldi?
No, I can go. I mean, there are a number of things out there. We have medical liability reimbursement, which significantly affects specialists. You know, when you're paying $70,000-$80,000 a year for medical liability coverage, that's significant, right? There's a business cost program that supports underserviced areas and rural areas, continuing medical education, and then obviously going on with the programs like MAPS, modernizing Alberta's primary care system, are huge issues going forward. And then not least of all that is then recognizing that somewhere in that we have to continue to progress with the equity piece, which is assessing that physicians are fairly compensated vis-a-vis their specialty, their training, etc. So those are all big time issues. The important thing about this announcement was that we have to start somewhere. Let's start with the stuff that is simple and obvious, that promotes physician trust in this government to say, hey, they're good, they're going ahead, they're promising, we're going to go with them, right? That's the huge deal.
And I think to add to that, one of the important aspects of the agreement is partnership. So we we're setting up as part of the agreement, in essence, a management committee to look at issues jointly and look at it from a interest-based standpoint, because there's so many common interests between government and doctors. How do we actually make sure that we find solutions that solve both the problems and then work through it and talk through it. So there's it's incredibly important, the process that we set up to be able to work together, and then we're going to continue to work through these issues, and like anything else is that we'll move forward with a solution, continue to monitor it. If it doesn't work, then we're going to pivot and keep going until we actually get it right. But that's the power of partnership, and very pleased that this agreement, this is such a key element of this agreement, is how we partner together to work through these challenges that we all are going to be facing jointly over the next few years.
Thanks, Minister. We'll wrap it there. Sorry we didn't have time to get to everyone, but I think that was a really good Q&A. Thanks to everyone who joined us online. Thanks, Minister, and thank you very much, Dr. Rinaldi.
Thanks, everyone. Have a great day.